Alright, time for us to test ourselves here. So a baby is born to a mother who was not immunized as a child. Great. Another situation where we have to remember those vaccines and immunization charts. That's not even a problem. Let's keep going. On gross physical examination, the infant appears normal, but on cardiac examination, the baby is found to have a continuous murmur in both systole and diastole. The physician prescribes a particular drug for the infant, and on follow-up, the murmur has disappeared. What is the mechanism of the action of the drug most likely prescribed? So you are really getting set up here for a great combination of micro, pharm, and embryology. So the mother was not immunized as a child. You will never likely encounter the patient like this unless you have a private clinic for Jenny McCartney. But that is the whole purpose of this question. Examiners want to know if you understand the concepts behind medicine. Think about some of the common childhood vaccinations that are important. Measles, mumps, rubella, tetanus, pneumococcus, polio. So that's great that we thought about those, but why is this important to the question? So rubella should be kind of dancing all over your screen here. The physical exam shows a continuous murmur in both systole and diastole. Diastolic murmurs are always abnormal, and when the heart is trying to fill itself, there should be no leaking in diastole. Some systolic murmurs are normal in a newborn, particularly if they're anemic. Remember when we discussed in the physiology section how you can have flow murmurs? But diastolic murmurs are always bad, especially if it's continuous. That means there's something going on all the time. The continuous murmur in both systole and diastole should be making you think patent ductus arteriosus. If you didn't think about this, no matter, we can still figure this out. So let's make a little timeline. Cardiac exam, murmur, give some sort of drug, baby's fine, and no murmur. So the doctor gave a certain drug here for the infant, and magically the murmur disappears. Well, we know it's not an ASD, a VSD, or some sort of structural defect. It has to be something that we know can respond to a manipulation of some sort of molecule listed in the answer choices. So let's put this story together before we even consider the answer choices. Indomethacin should have immediately jumped in your head here as the drug when you read that last statement. But this question is basically asking for the mechanism of action of a non-steroidal anti-inflammatory drug, specifically indomethacin that we gave in this case. So the mother was not vaccinated, and the vignette is wanting you to think that she gave her infant rubella via hematogenous spread. How does rubella cause the ductus to stay open? Well, the rubella virus actually lives within endothelial cells and vascular smooth muscle cells and cardiomyocytes. That's a really bad combination of places to live in a developing heart. So the rubella likes to infect these tissues. And what do you need to close your ductus arteriosus? Well, you need vascular smooth muscle cells to proliferate and contract down so that you close your ductus. And you need your endothelial cells to signal to fibroblasts, hey, come on in here and make some collagen so we can close our ductus. So rubella is a very terrible virus because it makes apoptotic proteins that just completely destroy these cells. Its main goal is to liberate itself from these cells and spread via the blood. And the best way to do it is to destroy these cells that it grew inside of. So you lose the collagen deposition, you lose the vascular smooth muscle cell proliferation and the contraction, and therefore you remain with a patent ductus. And that'll be the least of your problems probably because it also can damage the myocardium. But treating the rubella is not the question. How to close the ductus is the question, and the mechanism of action of indomethacin to close the ductus. So the administration of indomethacin will inhibit the production of what? Prostaglandin E2. Remember, indomethacin is a cyclooxygenase inhibitor. You need cyclooxygenase to produce the prostaglandin E2. Prostaglandin E2 is a potent vascular smooth muscle cell relaxing agent. If you eliminate it from the circulation, you'll have contraction of that ductus. Excellent. Let's continue. Alright guys, I know you're fading on me, just hold it together, let's go, let's get this. So what is this question even talking about here? 4-year-old boy at his pediatrician's office for a checkup. He looks well and is active. On cardiac auscultation, however, we have a low-pitched 2 out of 4 hollow systolic, so it occurs all of systole, murmur that is best heard at the left sternal border. This is our thorax, this is our sternum. Although the boy has no symptoms of a cardiac condition, the pediatrician orders an echo. What is the most likely diagnosis? Alright, so this is a very complex question. It requires you to know the anatomy behind where we auscultate for murmurs, the types of murmurs, the presentation of all of these murmurs, and then the age at which the boy presents, and the fact that he's well and active should lead you away from certain problems or potential diagnoses. So what about these other questions? Well, an atrial septal defect that is not in the location of the left sternal border. These are usually very quiet murmurs because the gradient of flow from the left atrium to the right atrium is usually very small. Mitral regurgitation is not something that you would expect in a 4-year-old boy. It's not necessarily a congenital heart defect. This is more of your classic presentation in someone with mitral valve prolapse, someone with rheumatic fever. Patent ductus arteriosus, we know, is a diastolic and systolic murmur. It is not just holosystolic, as we read in the vignette. A patent foramen ovale should not cause any problems unless for some reason you have increased pressures on the right side of the heart, which would allow you to push that foramen open. Remember, usually the pressures on the left side are so high that it slams that valve shut, so that there's no reflux of blood from left to right. So this baby would probably not be doing so well because the pressures on the right side of the heart would be higher than the pressures on the left side of the heart. So they've already reached pulmonary hypertension and the right ventricle is hypertrophied. So that's not a possibility, because a patent foramen ovale should not cause problems, unless you've reached the point where the pressures on the right side of the heart have increased enough to push this valve the other way. Now tricuspid regurgitation, that is a systolic murmur, but usually people that have tricuspid regurgitation at 4 years old have a lot of other associated congenital defects. So they wouldn't be doing so well, and they'd have symptoms of chronic regurgitation into the right atrium, such as an increase in the JVP. Now, ventricular septal defect is our answer for sure.